Welcome to tonight's webinar. My name is Maureen Martin, and I'm the Director of Programs for CAN-DO Multiple Sclerosis. Thank you for acting on the belief that you are more than your MS by attending tonight's webinar, Emerging Therapies with Dr. Randy Shapiro. I want to start tonight's presentation by talking a little bit about CAN-DO Multiple Sclerosis. CAN-DO MS is an innovative provider of lifestyle empowerment programs for people with MS and their support partners. We are the start of a whole new way of thinking about and living with MS. CAN-DO MS empowers people to move beyond their MS by giving them the knowledge, skills, tools, and confidence to adopt healthy lifestyle behaviors, actively co-manage their disease, and live their best lives. CAN-DO MS launched our new website last summer, mscando.org. And please visit the website where you can register for upcoming webinars, listen to archived webinars, check out our upcoming CAN-DO MS lifestyle empowerment programs, share your CAN-DO promise, and learn ways you can contribute to or get involved with CAN-DO MS. A few housekeeping items before we get started. Dr. Shapiro will address questions and comments at the end of the presentation, and we encourage questions throughout. To ask a question, you type your question in the chat feature, which is located on the left side of your computer screen. You should see a box on the left side of your computer screen that says chat. So to submit a question, you type in the small box that says chat with presenters. And this presentation is being recorded and it will be archived on CAN-DO MS's website. You're more than welcome to view the presentation again, and if you've missed one of our other webinars, you can find the archived version on the website. For those who are attending live tonight, you'll receive an email tomorrow with copies of this PowerPoint presentation. As many of you discovered when you logged into the webinar, new in 2011, you can listen to the live webinar through your computer speakers rather than having to call in. So the job of the live participants tonight is to, number one, submit your questions and comments in the chat box. Number two, complete the evaluation at the end of the webinar. And three, review the webinar schedule and register for the upcoming webinars. So we have a great speaker lined up for tonight's webinar. Dr. Shapiro was born and raised in Minnesota, and after graduating from Occidental College, he graduated from the University of Minnesota Medical School. Dr. Shapiro trained in internal medicine at the Wadsworth VA Medical Center, and then neurology under Dr. Baker at the University of Minnesota. Dr. Shapiro founded the first comprehensive MS center in 1977, the Fairview MS Center, which was renamed the Shapiro Center for MS in 2004. Dr. Shapiro was the first president of the Consortium of MS Centers. He was elected to the National MS Society's Hall of Fame and served on numerous advisory committees for them. He serves on the International MS Society's Medical Advisory Board and the national and local boards of the National MS Society, and on the medical board for MSAA. Dr. Shapiro has lectured and written extensively on all topics associated with management nationally and internationally. He is best known for his educating and patient management style, often using humor to teach some sensitive topics. Dr. Shapiro works for does work for EMD Serono and is a consult for Pfizer and Accorda. So before we get started with tonight's presentation, I just put a survey up on the screen. So just tell us about yourself. Are you a person living with MS? Are you a support partner? Are you a healthcare professional or other? We'll give everyone a couple seconds to submit their answers. All right, about 84% is a person with MS, almost 4% a support partner, and between a healthcare professional and other, about 7%. So that's a great diverse group we have on the call today. So with that, I will turn it over to Dr. Shapiro.
Well, thank you, Maureen. It's my pleasure to be here tonight. I am Randy Shapiro, and I appreciated the introduction that Maureen gave me. I'll tell you that webinars are a bit daunting at times, especially for me, because I tend to try to add a little humor to the discussion, and without an audience where I can see feedback and where people can maybe chuckle a little bit and I can get some understanding of whether people are understanding, it can be a little bit confusing. But we're going to move ahead and talk the way I talk anyway. You know, we're going to talk about emerging therapies and research and try to make some sense out of a very complex topic that is going on these days. The word research comes from the Middle French. It means to investigate thoroughly, and when we look at a real good source of information, Wikipedia, and actually it is a good source of information often, they are saying that it is an active, diligent, systemic process of inquiry aimed at discovering, interpreting, and I am emphasizing revising facts. And so what we're doing when we look at research is we're trying to interpret, discover, and change things so that our knowledge base improves and we move ahead. Managing multiple sclerosis, I've always said, is about what we all like to do is to change the course of the disease. So it's about disease management. And actually, for the first time, some 20 years ago, we got the opportunity to change the course of the disease and actually manage the disease. Up until that time, the backbone of managing multiple sclerosis was, and I will maintain that it still is, managing the symptoms of multiple sclerosis. And then we always have to understand that there's a person with the disease, and we have to manage the personal, social, vocational problems that people with chronic diseases have. So our tools for managing the disease and managing the symptoms and managing the problems of the person are pharmacologic, that is drugs, rehabilitative, and psychological types of tools. So when we look at what are the areas of research in multiple sclerosis, well, there's disease research, there's symptom research, there's person management research, there's pharmacologic research, there's rehabilitative research, there's psychological research. Not just one area. The areas of research are numerous. We have research into new treatments, research into genetics, research into the mode of action of not only drugs, but of the immune system and how our other systems interrelate. There's research into cell biology. There's research into virology. Are viruses involved? There's research into remyelination. There's, of course, research in symptom management, but there are also researches going on in social and personal impacts of MS, rehabilitation research, nursing research, economic research. So often we get so involved with the disease-oriented research that we forget that there's whole areas of research going on as well. Lots and lots of good areas. So I'm going to give you some background information into the understanding of research in multiple sclerosis. We are in the era of exploding knowledge, and we have been in this era of exploding knowledge for about 20-some-odd years. That sounds like a lot now, but in the scope of my life, it's not a lot. And most of my life and practice and professionalism, we were not in the era of exploding knowledge, but we got to the era of exploding knowledge, and we remain in it now because we learned how to study multiple sclerosis. We learned that we had to do randomized, double-blind, placebo-controlled clinical trials. That's really important to understand, that they had to be done properly, randomized, double-blind, placebo-controlled clinical trials. And the reason that we had to do them this way is that the placebo effect in multiple sclerosis, in virtually every study that it's been looked at, has been over 60%. By that I mean no matter what we do for people with multiple sclerosis, 60% of the time they will feel better and do better and actually look better and function better. And you can say that that's wonderful, why don't we just give placebos? 60% of the time they do well, but it doesn't last. It doesn't last. And why it works is anybody's guess for sure. We talk about endorphins, we talk about neurochemistry, we talk about a lot of things, but we don't really know why it works so well, mind over matter, but it does, but it doesn't last. And so we have to do these carefully done studies so that the investigator doesn't know who's getting the treatment and not. And the person who's getting the treatment doesn't know whether they're getting the treatment or placebo. And it's all done very objectively, because if I give people chicken soup, 60 to 65% of the time, they will feel better for a while. So we have to do double-blind studies that are well done so that we don't get in the situation where somebody says, okay, you caught us, but admit it, you've been feeling a whole lot better since we hooked you up to this phony machine 2 weeks ago. Randomized, double-blind, placebo-controlled trials. You know, there were a lot of MS treatments that have been in my lifetime that did not follow the rules. And they were very, very popular for a short, sometimes moderate length of time because people got so excited about it. When I started practicing multiple sclerosis medicine in the 1970s, pregnant cow's milk that was hyperimmune, colostrum, taken from the cow who had just given birth to a calf, that was the answer to MS. And people all over Minnesota were throwing away crutches and canes and walkers and saying they were cured because they got their colostrum. Nobody talks about colostrum now. Matter of fact, nobody remembers it. Some of you may remember cobra venom because it was a national scene situation on 60 Minutes where the cobra venom clinics in Florida were curing multiple sclerosis, but the MS Society was ignoring it. Well, the MS Society stopped ignoring it, actually gave them $300,000 to do research, and it turned out to be a phony scam. And they lost the money. And now nobody talks about utilizing cobra venom. Mercury amalgams were popular for a while. Remove that mercury, and you can dance on the dance floor with Mike Wallace. That's what 60 Minutes said, but it didn't really work. Bee stings, that was popular for about 6-7 years. I would give talks, and people would get angry with me because I would say it doesn't meet the criteria. It doesn't work. And yet, people were doing better, and now you don't see people doing bee stings very much anymore because it doesn't work. Hyperbaric oxygen was popular in the 1980s, even had some literature showing that maybe it was of some benefit, but after much research, much money, it turns out it is a benefit for other diseases, not multiple sclerosis. Goat serum, much like colostrum, was popular. There was a doctor in Arizona who thought he answered MS by holding onto a battery and holding both sides of the battery and letting the charge go through him. That never got too popular. But there was a woman in the 1980s who put clogs on her feet, rocker clogs. These were just clogs like you'd wear in Holland. And she could walk magically, but when she took the clogs off, she couldn't even sit in a chair. Low-dose naltrexone is a 2000 decade, if you will, medicine that did not follow the rules of the randomized double-blind placebo-controlled trial. There have been many diet and nutritional treatments. Magnets were popular for a period of time in the 1990s. I had many patients bringing me magnets and telling me that I should sell magnets because that was the answer to MS, but we don't hear about it now. And in the early 1980s, there was even a surgeon in California who thought he should operate on the back arteries of the brain and that fixed MS, and he published an article on it, and it was popular for a very short period of time because that surgery was dangerous and had no relevance to multiple sclerosis. Not done in a randomized double-blind placebo-controlled trial. So I understand, and you understand, that there is hope. But then there is false hope. And whenever I discuss treatments like this, there's always somebody who gets mad at me. Always somebody who thinks I am a sham and I'm proselytizing for things that they don't like because I've attacked their hope, if you will, in a management strategy that has no basis in fact. And I apologize to them because that's not my intent. My intent is to just provide facts to people. They could come to their own conclusions, but I'm not going to pretend that I don't have conclusions, and I'm not going to pretend that something is valid when I don't really believe it's valid. We are in the era of exploding knowledge now because we learned how to do randomized, double-blind, placebo-controlled trials, and we learned that we had to study populations of people with multiple sclerosis. By that I mean beforehand, before 25 years ago, we used to study multiple sclerosis, but we studied multiple sclerosis as a disease of all comers, if you will, with MS. So we had people who were bedridden studied next to people who were ambulatory, and we learned not a lot. Nothing worked. Nothing worked. We learned in that era 25 years ago that we had to separate people into groups who looked more alike so that we could study them and not study the whole variety of multiple sclerosis. So this next slide in a way shows that why, yes, most of the medical research on your treatments was done by men on men. Has that been a problem, Ms. Pinsky? You know, we had to look at multiple sclerosis in patterns. And so groups got together. Fred Lublin brought a group of people together, and they said, what can we do to group people more appropriately in a unified fashion? We had patterns of MS before this particular pattern was accepted, but they weren't uniformly accepted. what we decided some 25 years ago was that 80 to 85% of people with multiple sclerosis began their journey with fluctuations of the disease. So we labeled that as relapsing remitting multiple sclerosis. And we knew that over half of them along the way would stop having those relapses and slowly get worse. And we changed the name of those people to secondary progressive multiple sclerosis. 10% of people with MS got worse from the get-go, so we called them primary progressive MS. And 5% didn't read the book and started progressive and then began to relapse, so we called those people progressive relapsing multiple sclerosis. Now, we knew that it was all multiple sclerosis, but by dividing people up into these patterns, we could do research and we could separate them into groups that would look alike, and maybe we could be successful. And by doing that, we discovered something. The first drug that was approved for multiple sclerosis was beta-seron, interferon beta-1b. And it was studied in the relapsing remitting group in a randomized, double-blind, placebo-controlled trial, an excellent trial. And it was approved because it showed a decrease in the relapse rate and a decrease in MRI activity. And when the FDA approved it, they said this drug is approved for, and we all expected them to say, multiple sclerosis. But what they said was this drug is approved for relapsing remitting multiple sclerosis. And it was like we had the birth of a new disease, relapsing remitting multiple sclerosis. But it isn't. It's just a pattern of multiple sclerosis. One of the 4 patterns of multiple sclerosis. They're all multiple sclerosis, or are they all the same? You know, the average age of onset for relapsing remitting and secondary progressive, which make up 85% of people with MS, the average age of onset, I'll say that again, for relapsing remitting and secondary progressive MS that make up 85% of people with MS is 30. It's a disease of women, almost 4 to 1. It's a disease with lots of abnormalities on the MRI of the brain and lots of spinal fluid abnormalities of an immunological character. That's 85%. The primary progressive relapsing make up about 15% of people with MS. The average age of onset for them is 50. It's a disease that's 1-to-1 male to female. It's a disease that has less MRI activity in the brain, less immunologic activity. It's mostly a myelopathy that is more progressive in nature. By myelopathy, I mean spinal cord disease that is progressive in nature. Maybe we have 2 different diseases that we're looking at in these patterns. Or is that right? The Mayo Clinic actually looked at biopsies and autopsies of people who had multiple sclerosis, and they found 4 different types of multiple sclerosis, not these types, but different types, type 1, type 2, type 3, type 4. I'm not going to get into that in a lot of detail except to say these were based on immunologic and pathologic characteristics. No 2 people had more than 1 type. In other words, every person had one of these 4 types. Everyone had an individual type. They weren't uniformly distributed, but suffice it to say they ranged from the very immunologically active to the very not immunologically active and more degenerative, if you will. The point I want to make is that there may be many varieties, if you will, of multiple sclerosis, but these clinical patterns of multiple sclerosis, relapsing remitting, secondary progressive, primary progressive, progressive relapsing, were never meant to be thought of as separate diseases, even though they're sort of becoming that way because insurance companies view them that way. The FDA seems to view it that way, but they're really not meant to be viewed that way. If we take a snapshot in time of people with multiple sclerosis in the community, we see that 55% of them have relapsing remitting, 30% have secondary progressive, and then we have the 15% of progressive relapsing and primary progressive. Who performs MS research? Well, a large amount, the bulk of MS research comes out of the pharmaceutical companies and biotech companies. They are actively involved in it because they're for profit, trying to make a dollar, and that is influencing their activity, and this has become an area that's very important to them. Much of the basic research comes from universities and then gets moved on into these other more profitable companies, if you will. There are nonprofit research institutions doing research in MS. The National Institutes of Health does research in MS, and there are non-affiliated groups and individuals who do research in MS. So how is research conducted? Well, the main type of study that's used to research new treatments is the clinical trial, but there are other studies such as population surveys, quality of life questionnaires, tissue cell examination, laboratory research, which is quite basic. To get approved by the FDA, a drug has to go through certain clinical trials to be approved. And the first one is called Phase 1. And this is a trial that focuses on safety. And usually it may be normal medical students who are taking this drug for a fee, or people who are volunteers. What we're trying to find out is this medication going to be safe in an individual? We don't know the dose. We hope it's going to work, but we're just trying to figure out safety. Once we find it safe, then we go into a Phase 2 clinical trial. The Phase 2 clinical trial is typically randomized and blinded. Its focus is on efficacy and safety, but really we're trying to find a dose. What's the right dose that is safe to give to see if a drug is going to work? That's the Phase 2 trial. If we pass that trial, we go to the Phase 3 trial, and this then is the randomized, double-blind, placebo-controlled trial that has to be populated with enough patients that we can see what the safety and efficacy is with certainty. And if it passes that, then it goes to the FDA and gets approved, and then it hits the marketplace, and then there are more studies that go on after that called Phase 4 trials, studies to make sure that it stays safe over time. This takes a long time to get through, almost 20 years for a typical drug. And then we come up with data. And we all believe in evidence-based medicine. You have to believe in evidence-based medicine, but that's not all. We also have to put our experience into medicine and understand that experience and evidence come together in the practice of medicine. So we get the data, but sometimes the data doesn't make any sense. And so I steal a term from Joe Souchere, who is a columnist in the Twin Cities for the St. Paul Pioneer Press and a radio personality for KSTP Radio, who has a show that was called Garage Logic. And what he used to say was that you had to have common sense thinking. And that can be done in the garage where you're away from stress. And recognizing that data is not always the end-all. Sometimes experience is extremely meaningful in managing a disease process. So that's some of the background to research. Now let's talk about some of the research that's being done these days. And I want to talk about symptom research first. And I want to talk about 4-aminopyridine, dalfampridine, Ampyra. And as it was disclosed, I'm a consultant for Accorda. And so I've participated in the research on this particular drug, and so everybody should understand that up front. I don't think that biases me, but you should understand that. 4-aminopyridine is a potassium channel blocker that allows demyelinated nerves to conduct more efficiently. You know, nerve conduction is a combination of electricity and neurochemicals. And when you have demyelination, that conduction does not conduct efficiently. It blocks. And by blocking the potassium channels, we allow the demyelinated nerves to conduct more efficiently. It's been in research for 20 years. We've known for a long time that it causes an increased possibility of seizures in people who are seizure prone because it does stimulate this electrical activity. So you see the nerve, and you see the axon, and you see the myelin, and you see the nodes of Ranvier, and normally nerve conduction skips along those nodes. And as you see in this beautiful picture from Bruce Trapp from the Cleveland Clinic that's used in every MS talk that I've ever seen these days, you can see that between the arrows in the middle of the page, the yellow axon, if you will, the yellow nerve lined with two red lines on each side of myelin. And then next to it, to the right, you see the green axon that doesn't have those red lines of myelin, if you will, because it's demyelinated. And right above it, you see the axon that is broken because it has lost ability to stay alive, if you will, and so the axon is lost. It's degenerated. It's cut, if you will. We need to prevent that cut, if you will. But what dalfampridine Ampera does is it allows that demyelinated nerve to conduct more efficiently through that area. So that is a drug that was just approved by the FDA just over a year ago, year and a half ago, and is now available for people who have problems with walking because it was studied in people who have walking problems. The word spasticity comes from the Greek word to tug. It is a velocity-dependent stiffness. By that I mean the faster you move the extremity, the leg, arm, the stiffer it gets. It's part of a syndrome that we see when there's damage to the nervous system. One of my patients gave me this picture, and this is what spasticity is like. That the young doctor doesn't do this more than once, stand in that position, because when you tap that leg that's stiff and spastic, it swings up very rapidly, and you recognize that's not the place to stand. But we've had advances in spasticity, and the latest advance that came about just a couple of years ago is Botox. Botox has been used as an anti-spasticity agent for a number of years off-label, but now it has approval, and we can take this Botox and we can inject it into a muscle, and it will decrease the spasticity of that muscle. It works for about 3 to 4 months, and that muscle looks beautiful. The wrinkles disappear. No, I'm just kidding about the wrinkles, but it actually works very well. But in MS, often there are many muscles that are involved, and so that we have to be careful not to use too much Botox. It costs a fair amount, but also it is a toxin, and if we use too much, people will get sick. Marinol, cannabis, has been talked about a lot for spasticity for years and years and years, and it's been talked about a lot for multiple sclerosis. And in fact, there are cannabinoid receptors on the central nervous system cells, and there are cannabinoid receptors on the immune system cells, so there's some thought that maybe cannabis would have an effect on the immune system, but that hasn't been studied thoroughly. But there is a medication that's working its way through many countries. It's been available in Canada for a while. It's been available in Europe, and it might become available in the United States. It isn't yet. That is a cannabis, if you will, marijuana spray called Sativex. And in some smaller clinical studies, it has been shown to reduce pain and sleep disturbances. But there have been some cognitive issues and dry mouth, and there are issues associated with it, but it is something to look for. Not available in the United States as yet. We've known for a long time that cognition is involved in multiple sclerosis. It makes sense in a way because MS is a white matter disease, and that's how you transmit your thoughts, is through the myelinated fiber tracts of the brain. But in fact, what we're learning is the gray matter is involved in multiple sclerosis as well. And so research into cognition is important. I can't remember if I have short-term memory loss or long-term memory loss. Sometimes I don't remember where I am. I'm in a hotel room half the time, it seems like. So we've studied ginkgo biloba, certainly a popular treatment for people. Could it improve cognition? Well, it didn't. It didn't. We've studied in some studies Aricept, a medicine for Alzheimer's disease. That didn't work very well either. In one study, Provigil modafinil, which was used in conjunction with Avonex, improved cognitive function. There was a significant improvement in cognitive function compared to Avonex alone, but not enough to make this a good study that the FDA could give an approval of. This just gives us an indication that maybe more research could be done in this arena. A drug called memantine was studied in cognition, another Alzheimer's drug that did not work well in multiple sclerosis. We know that pain is a problem in multiple sclerosis as well, and it's a neuropathic burning type of irritative pain. The pain medicines don't work very well at all for this kind of pain, and it is a problem in over half the people with multiple sclerosis. So some studies done with the newer anti-epileptic agents, such as pregabalin, Lyrica, versus an antidepressant, showed that pregabalin, the drug that's used for diabetic neuropathic pain and shingles neuropathic pain, improved MS-related pain. Again, it's not approved for this, so this is off-label, but there are studies to show that it has some hope in this area, some hope. There's an interesting set of symptoms that people don't think about unless they see it or deal with it. You know, when you have disease of the brain in a diffuse fashion, sometimes your emotionality becomes uncontrolled. Sometimes people laugh inappropriately, sometimes people cry inappropriately. And we've known this for years. And that happens in multiple sclerosis as well. I've had many people come into the office and I'll just say, "How are you?" And they'll just burst into tears, but then they'll tell me they're fine. So there was no real reason for that bursting into tears except the brain couldn't suppress and control their emotions. This is called pseudobulbar affect, or PBA. And an interesting study and an interesting medication that combines an ingredient in cough medicine, dextromethorphan, with a heart medicine, quinidine, in an interesting way called Nuedexta, has been approved by the FDA this past year. So it does work on the neurochemistry of the nervous system to suppress this hyperemotionality, a new medicine for symptomatic management. Many of the medicines that we use for disease management have been aimed at the immune system. And so I think it is helpful to understand how the immune system works. And the immune system is all over the body. You know, the immune system is in the tonsils, in the lymph nodes, it's in the thymus, it's in the spleen, it's in the gut, it's in the bone marrow. It's all over the body. But if you look at this diagram, you'll note it's missing that it's not in the central nervous system. It's not in the brain and spinal cord. So for that immune system to be involved in MS, a number of things have to happen. And I recognize that this next slide is complicated, and I'm going to walk you through it, but even if you can't see it, it doesn't matter, because I hope that I'll be able to explain it well enough, even if you don't see this. But what happens is that the immune system has to be programmed. The cells in the immune system have to be programmed to attack something in the central nervous system, in the brain and spinal cord, that they have never seen. They've not seen that. So something outside in the environment has to program that cell to attack something that it hasn't seen. Then that cell that has been programmed has to get into the blood vessel. And it gets into the blood vessel and it circulates. But to get to the nervous system, it has to pass from the blood vessel, through the wall of the blood vessel, into the brain and spinal cord system, into the central nervous system. It's not easy for that programmed immune cell to get through the wall of that blood vessel because there's a barrier that prevents it from getting through called the blood-brain barrier, blood-brain barrier. So for it to get through, it literally has to be pulled through by some molecules that are called adhesion molecules. So this cell then gets pulled through the blood-brain barrier into the nervous system, where it then can find what it's programmed to damage, which it hasn't seen before. It's all very complex, but knowing that pattern, we can develop treatments that might in fact modulate the disease by hitting certain areas as they occur. So that was the birth of natalizumab, Tysabri. Tysabri is a drug that suppresses that carrying of the cell through the blood vessel wall. So that drug was the first drug that was really developed with the idea of preventing one of the mechanisms of action of multiple sclerosis. Now, Gilenya does this in a different way. It's the new drug, Tysabri is natalizumab. Gilenya does this in a different way by preventing the immune cell from escaping the lymph nodes. So by catching that cell and inhibiting the receptor that allows that cell to get out of the lymph node, it gets trapped into the lymph node and it doesn't escape. So that was a different category of disease. We have research now going on into other medications that may modulate the disease. Lipitor, a cholesterol agent, has been researched pretty thoroughly and has been pretty well given up upon, I think. But it does promote a response in the immune system that is beneficial to MS at certain dosages. Certainly, chemotherapy, attacking the cells and destroying the bad cells, if you will, and can modulate the disease. And that type of chemotherapy, if it's done properly, is so suppressing to the immune system that we have to give stem cells to replace the immune system. Otherwise, the person would not be alive. And so we have stem cell mobilization with cyclophosphamide. We talked about Gilenya, which is fingolimod, as a new oral agent that works by preventing the lymphocytes from exiting the lymph tissue. We have a drug called BG12 that is an oral agent that has been used in psoriasis that is not approved yet for multiple sclerosis, but preliminary studies look really good for this medication with good reduction in relapse rate, good reduction in MRI activity. So we'll see whether it continues to look good as it passes through its studies. It looks fairly good at this point. We'll see what its safety and efficacy is over the next year or so. Laquinimod is a unique immunomodulatory drug that's more like a chemotherapy drug and mimics a drug that we studied many years ago called linamide. The studies in laquinimod have not been as exciting as we maybe would have hoped. Now, this is me talking. I have to say that. If the company were talking, they would probably tell you how exciting they are. But my view of this is that laquinimod is, the results thus far have not been as I would have hoped they would be. But the studies continue to go on, and we'll see whether they turn out to be better over a period of time. Campath, alemtuzumab, is a very potent monoclonal antibody that has been used for some treatments of cancer in the past and is now being used in multiple sclerosis research as a cell that targets this particular antigen expressed on mainly B cells but also T cells. This is a very potent medication that in studies with recent results being reported has been really quite exciting, except that its toxicity has also been something that makes us raise our eyebrows. And so we have to always look at the risk versus the benefit of all of these new treatments. Oral cladribine has been a bit of a disappointment and is no longer being researched and no longer being thought to market because while the studies were done and the studies looked really good, they weren't enough data for the FDA to make an approval of it. And apparently it was decided that this should not move any further in research. And so for the moment at least, that has been vacated. There's research done into taking T cells and making a vaccine that would be different from person to person and changing the immune system of people by vaccinating them. Those look hopeful in preliminary studies. There are a number of other drugs that really have a lot of hope behind them. There are new studies going on with ocrelizumab, which is a drug similar to rituximab that has been shown to work in some forms of relapsing multiple sclerosis. Teclistamab is another drug that has some real interesting thought process behind it because it has an effect on certain cytokines that are shown by genetic studies to be of importance in multiple sclerosis. There is a new formulation of Rebif out there in the world that may eventually work its way to the United States. High-dose vitamin D is very intriguing in our thought process because the epidemiology, the studies of factors in the environment, make us look at vitamin D as a potential either contributor to multiple sclerosis or even major contributor to multiple sclerosis. And so that is being studied very intensely, and it should be studied very intensely. The drug for asthma, Proventil, is being studied in multiple sclerosis. Dr. Zamboni in Italy came up with a theory that multiple sclerosis is caused by chronic cerebrospinal fluid venous insufficiency. And that's been studied here in the United States by Dr. Zavadnov, and so we have the two Z's, if you will, talking about CCSVI a great deal. And in some countries, this has really become very popular, but I have to tell you that it makes no sense to me when I understand things about multiple sclerosis the way I think I understand them. Everybody has veins that look different, and some of these veins look narrow at times, and at other times they don't look narrow, and by putting pressure on them, you can make them look narrow, and they are very loosely filled vessels that have slow blood flow and can multiply, actually. And so when I think of this whole process pathophysiologically, what makes MS as a disease, this doesn't make a lot of sense to me. And I know when I say that, people get mad. Some people get mad because they really want to believe CCSVI is the answer to MS rather than a pipe dream. But that's the way people felt about bee stings. That's the way they felt about colostrum. That's the way they felt about goat serum and everything else. You know, we know a lot about MS. We know that it's a disease mainly of women. It's a disease of the brain and spinal cord. It's a disease that increases as you move away from the equator. It's a disease that involves the immune system. It's a disease that is modulated by immune modulators. It's a disease that involves inflammation and degeneration of myelin and axons and little else, interestingly enough. It's a disease with some genetic characteristics. So every therapy really has to account for the epidemiology of MS. So do venous abnormalities occur only in white women because this is a disease primarily of white women? Do venous abnormalities account for the spinal cord, which the circulation is very different from the brain and really is very segmental and doesn't rely on any single artery or vein? Do venous circulations change in people who move away across the equator? What does the venous system have to do with the immune system anyway? And how does this have to do with immune modulators? Why would an immune modulator have something to do with the venous system? And what does that have to do with inflammation, degeneration of myelin and axons and little else? And what does that have to do with genetics? Lots of venous systems are different from person to person with no obvious change in multiple sclerosis forming. And strokes involving the veins of the brain are rare, but when they occur, there's no MS or demyelination associated with them. And in fact, veins regrow when the circulation is impaired. We see that all of the time. Radiation and cancer surgery with venous destruction does not cause anything that looks like MS. And then there have been study after study after study now, with lots of money being spent, showing that real-time venous circulation with catheters fail to show the changes that have been talked about. So I mention this because of its present popularity among some folks. But to me, and this is me talking, you can be mad at me if you like, but that's just the messenger rather than the message, I think. The results mimic cobra venom, bee stings, and when I sit in the garage and think about it, it makes no sense. We have better things, I think, to spend our precious research dollars on. But we should do a randomized, double-blind study with sham surgery with no input by any surgeons to see. This would be very simple to do, and it's being. These things are being done, and as they get done, we will have some knowledge that will teach us something. I hope I'm wrong. I've been wrong before, and if I'm wrong, I'll be the first to admit I'm wrong. But so far, I don't think I'm wrong, and I think a few years from now, we won't be talking much about this. But we are talking about genetics because there is a genetic issue that goes on in MS. We know that there's increased susceptibility from chromosome 6, and there are linkages involving chromosome 3, 5, and 19. We've learned that from studies that were supported by the National MS Society and the National Institutes of Health. We know that the likelihood of getting MS just out of the air is about 0.2%. If your mother or father has MS, and if you're a woman, the likelihood jumps to 4%. If you're a man, it's 2%. If your identical twin has MS, it's 30%. So that tells us there's some genetics involved in this, but it tells us also that this is not an inherited disease, because if your identical twin had MS, it would be 100%. And we know that that stem cells are very interesting types of cells, because the pluripotent stem cell can be made into nerves. You can generate nerves. And in animals, we can remyelinate. But it takes, thus far, unfortunately, an embryonic stem cell to make that cell. So I thought I'd show you a picture of an embryo. We're not talking about a fetus here. We're talking about an embryo. It's a group of cells that is just a group of cells and will be thrown away if it's not utilized. And so hopefully we can use these cells to develop treatments for multiple sclerosis. That probably won't be the answer, because something has to stimulate the disease process in people, stimulate that immune system. Maybe it's a virus. So we've had viruses in every decade that we've looked at, and today it's the EB virus, the Epstein-Barr virus. The Epstein-Barr virus is a mononucleosis virus, and we see that a lot in people with MS, and so that research into that is being done in a large, significant way. And we should be doing research into complementary treatments. And we did a research study on prayer in multiple sclerosis. I'd like to tell you that it worked, but it didn't work. But we did do it. There have been studies in omega-3 fatty acids that have been mildly positive, but not really seriously positive. But we need to study these things. Your cholesterol is too high and your fiber is too low. Stop eating all those eggs and start eating the carton they came in. You know, around my house, we have the 4 major food groups: junk, fast, frozen, and spoiled. And research into exercise. This is an exercise pill that actually works. We need to continue the research in exercise that can do multiple sclerosis when it was called the Jimmy Hugo Center started and popularized. So we have to do research into these studies. And in research into acupuncture, for example, I suggest we try some acupuncture. And yeah, Clem, I hurt, but you know, it's a good kind of hurt. Well, sometimes I feel like you're damned if you do, and you're damned if you don't. But sometimes you have to try one or the other. So now, Maureen, I think we have about 10 minutes or so, and I'll take whatever questions you deem that I should be taking here.
All right. Thanks, Dr. Shapiro. And I was laughing at your jokes and your comics, so I'm sure the rest of the group was
I hope
as
some
well.
people will laugh at them and not be mad at me for utilizing them, but that's just the way life goes, isn't it?
That's great. So we have time for just a few questions. So the first one, this is an interesting question. What country do you think has the most progressive treatment for MS?
Well, you know, that was a question that would have had a lot of relevance, I would say, about 20 years ago, because, you know, I've been around, as you know, because you know me, a long time. And I was in practice for 35 years taking care of people with multiple sclerosis, and I would say for the first half of that or so, the United States was about 5 years ahead of the rest of the world. I would go over and lecture in Europe many times, and I have many times, and I would be under the impression that we were about 5 years ahead of them throughout that whole period of time. Now, all that's changed. All of that has changed because of the Internet. The Internet has allowed communication between researchers to be instantaneous. And so now there is no such thing as a country's research. It's an international research. The research studies that are done in the United States are being done in Germany and done in Great Britain and Spain and in all of the industrialized nations that have research laboratories. So I can honestly tell you that I don't believe that there's one country that is ahead of another country in MS research. They're all working with the same goals, the same ideas. All of the meetings that are of any import are international meetings that have input from all over. And so we're all in this mess together.
Great. Thank you. The next question, and this question arose when you showed the chart of the different types of MS, and this person asked, does everyone eventually end up with secondary progressive MS?
Well, that's an easy one to answer, and the answer is no. Not everyone eventually ends up with secondary progressive MS. As a matter of fact, before we had any treatments, there were 20% of people, and this remains true now, 20% of people who had MS who just didn't get worse. They had MS, and for whatever reason, they stabilized and didn't get worse. We used to talk about MS before there were treatments as about a third of the people who got MS got really bad. About a third of the people who had MS got moderately bad. That is, they had some walking problems, but they still functioned and got along fairly well. But a third of the people, this is before treatments, did fairly well, even though there were no treatments. Now we'd like to think that we are changing that ratio toward more people doing well for longer periods of time. It's really hard to get long-term data because people are in treatment, out of treatment, changing treatments, doing this, doing that. Everybody's a little bit different. Hard to study them and keep them in studies. But if you ask any doctors, any older doctors who have been around, who have been able to see the change in MS centers, they will tell you that they've seen a distinct change in multiple sclerosis in the past 20 years for improving people's capabilities over that period of time with less people becoming more progressive. So by no means does everybody become progressive. But I'm going to add something else. This isn't in this research thing. This is just me giving you experience. That everybody who has progressive MS stops progressing at some point. It's almost everybody. It's very rare for people to continue to progress forever. They stop progressing. Our goal as as physicians is to try to keep people from getting worse as they might ordinarily. That's our goal, to slow disability. That's why we love the tools that we've gotten available now with these new medications. But the fact of the matter is that the disease itself tends to want to burn itself out as people get older. Usually in their 60s, it tends to do that. We actually now have data to show that.
Great, thanks. And then we received a few questions about Impera and thought maybe you could just generically answer them. One about how to tell if it's working, and the other one about maybe some side effects like seizures and things like that.
Well, how do you know it's working? You know it's working if you're walking better. That's how you know it's working. This is a drug that helps people walk better. It works in about a third of the people, just over a third of the people who take it. That means 2/3 of the people who take it, it won't help them. So if somebody is having a walking problem and they take Impera and they're walking better, that's how you know. You know it. You know yourself. It's not anything magic. Now, you can measure walking. We certainly did that in the studies, in the randomized, double-blind, placebo-controlled trials. We measured walking. But MS is a disease with great variability. One day you're down, one day you're up, one day you're this, one day you're that. So you really need to take this thing and see whether it actually does help you walk. And then you might, if you're not sure, you go off of it and see if you're not doing as well off of it. So it's not really rocket science. Now, we can turn it into rocket science with insurance companies asking for 25-foot timed walks and for disability measurements and for taking it and measuring it 6 weeks later. And that's not really my way of looking at it. Does it work for the individual? Do they feel better taking it than not taking it? If they don't feel any better taking it, they shouldn't be taking it. Side effects are those of a stimulated nervous system. So sometimes there's dizziness, sometimes there's clumsiness, sometimes there's the feelings of irritation, if you will. But they're relatively rare. The seizure side effect we can't play down in any way because that is more serious. And so if there is an indication, if a person has a past history of seizures, or think they may have seizures, they may need further testing into that. They shouldn't be taking it, period. They just should not be taking it. If they have renal disease, which is rare in MS, kidney disease, they shouldn't be taking it because the dose will build up, and that's not a good thing. But otherwise, it's pretty well a drug that you try it and you see it and see whether it works, and if it works, you're happy, and if it doesn't work, you don't take it.
Great. Thanks, that was good. The next question, there are a couple about this. What causes demyelination?
Well, we know that the demyelination is caused by the immune system, if you will, attacking the nervous system. That something in the myelin, or the cell that makes the myelin, the oligodendrocyte, is attracting a programmed cell to attack it, a programmed T cell. So that we know. The question is, what is it that's attracting it, and why is that occurring? And that's been the question that will probably win a Nobel Prize for somebody at some point, that we don't know. So we can somehow, in some cases, stop that attraction by the methodology that we talked about in the lecture, but we still don't know the whys and wherefores of that occurring.
Great. The next question, do you know if there are any studies being conducted on the long-term use of Tysabri?
Well, I'm sure there are studies being conducted by companies that are following people. The Biogen folks, I'm sure, are following the people that are registered through the Touch program over the long haul. These studies are really hard to do over the long haul because people drop in and drop out of treatments and things of that nature. People are being followed, and we'll see what the results are over time. They're not as formally done as the randomized double-blind placebo-controlled trials that get the drug approved. And so they're not as good quality over the long haul, these long-term studies. So we have to take a step back sometimes and say, just what is going on here? And sometimes if you're viewing it too closely, you don't see the issues that may be occurring with any one drug.
Great. And we have time for one last question, and there are a few on this, so I thought this would be a good one to end with. You talked about vitamin D. And is there a amount that's good for you for someone with MS, or how do you kind of judge that?
Well, I'd like to tell you that I know the answer to that, and that everybody should take, and I'm not going to give you a milligram, even though I do have one that I recommend. I'm not going to say it over this because it's just my view. We really need the data to tell. What appears to be true is that many people with and without multiple sclerosis in all over the country, all over many countries, appear to have relatively low vitamin D levels. Why they're considered low is because somebody says that this is normal and they're low. But do we really know what a normal vitamin D level should be? And that are all people, no matter what race they live with, are they all have the same vitamin D level opportunity? I say that because skin pigmentation does have an effect on absorbing vitamin D. So these are questions that we don't know the answer to. So there are lots of questions, lots of issues, but it appears that vitamin D is a safe treatment to take. It appears that it's not expensive. And it appears that it has some relevance, but just exactly where it fits, we don't know yet. So vitamin D metabolism, a lot is known about it, but the role of vitamin D in diseases like multiple sclerosis, that's in its infancy, so to speak. So we look forward to more studies and more data that will give us an indicator of just what role does vitamin D play. And then I would hope that science would tell us exactly what the dosage range that we should be taking. I have heard virtually everything that you'd want to hear, from 200 milligrams or 200 units to 5,000 units a day, to 25,000 units a week, to taking it this way, taking D3 versus vitamin D without the not D3 formulation. So you know, nobody really knows. I hope that in the next time that we give this type of seminar, we'll have more data that will tell us more about it, because it certainly is intriguing, if not really important.
Great. Thanks so much, and thanks for answering all of those questions. And Dr. Shapiro, do you have any kind of last closing thoughts for this group?
Well, I know that there are a lot more questions, and I can see that there are a lot of questions that are quite personal in some ways, and I wish that I could answer them all. I think that becomes an impossibility. I just want people to know that we are in the era of exploding knowledge. You know, it's never a good time to have multiple sclerosis. I'm not going to pretend that there's a good time to have multiple sclerosis, but I can tell you quite honestly, having been there, that this is a better time to have the disease than it was 25 years ago. And hopefully over the next few years, as we see more and more breakthroughs coming through, it will be even a better time for people to have multiple sclerosis. But I'd like to see a time when no one has multiple sclerosis. And maybe that's a pipe dream, but I hope to see it. And I wish everybody well and to stay in as good a health as they possibly can be. Thank you.
Thank you so much. For everyone's information, the next webinar is on September 13th at the same time, 8 p.m. Eastern. And the topic is Support is a Two-Way Street, Tips for Partners Who Care About Each Other, with Rosalind Kalb. You can register for this and the other webinars at mscando.org. And for those participating live tonight, as soon as the presentation is over, you'll see a survey appear on your computer screen. So please take a moment to complete the survey and help us continue to improve our webinars. And we value your feedback and input. Thanks again, and have a great night.